Hi everybody and welcome to our next podcast as part of the NHS Confederation's NHS Reset work. We're here today to talk about health inequalities, in particular looking at what's needed for the LGBTQ plus population to recover from COVID-19 as we move into the recovery phase after the second peak that we're facing at the moment. It might seem a bit unusual that we're actually talking about recovery, but it's important for us to be proactive in making sure that organisations have the preparation, resources, ideas and tools in place so that when we do start looking at recovery, actually our LGBTQ plus communities' health inequalities are prioritised and we can focus on tackling the issues that the community may face. It's a real privilege today to welcome such a fantastic group of colleagues to have a positive conversation, and we're really going to have a bit of a chat around what the issues everybody here feels that we should be looking at across the diversity of our third sector and NHS organisations looking at health across England. Rather than myself introducing everybody today, we've got some fantastic characters, so I think it would be really great if the panel could introduce themselves. So I'm going to pass you over to one of my first colleagues who's going to say a few words about themselves. So Peter.
Hi, and hi everyone. I'm Peter Molyneux. I chair Sussex Partnership, NHS Foundation Trust, and I'm also one of the co-chairs of the Health and Care LGBT Leaders Network that's supported by the NHS Confederation. And I'm really interested in how we can use the COVID-19 pandemic to develop new community-led models of health and wellbeing.
Great, and I think I'm next. My name is Caroline, and I am the Chief Executive of the Royal Free Group of Hospitals in North London. I'm a lesbian and I've been out since 1987, and I am interested in how we can make the NHS a much more inclusive place to work, because I think that genuinely translates into better patient care. So really excited to be on this call. Thank you.
Hi everyone, I'm Gary Eaves. I work in Nottingham in the Nottingham and Nottinghamshire CCG as the Head of Mental Health, Learning Disability and Children's Commissioning. I identify as a gay man and have been on my own journey around my own understanding of the impact of sexual orientation and gender in the workplace and also in services that we deliver, and have become a lot more active in terms of seeking to change the way that we work as a system to improve and reduce inequalities.
Good morning. Hello, should I say? My name is Ramses Underhill-Smith. I am the Managing Director of Alternative Care Services and ACS Plus, and we are the first LGBT-focused domiciliary care and actually supported living care in the country. And we've been going for 4 years now. We've just started this year our supported living services as well for LGBT people. So.
Thanks everybody. It's great to see such a range of experiences and talent on the call today, and I know that I'm going to take away some learning, and I'm sure everybody watching today is going to actually learn a lot from your experiences and thoughts on how we move forward as we're looking at recovery and tackling LGBTQ plus health inequalities. I just want to myself, often with these events you have a chair. I've been very clear that I'd love to be more of a facilitator and someone who's helping the conversation go along. So I'm Tara Hewitt, my pronouns are she and her, and I'm currently the Group Equality and Inclusion Programme Manager for the Northern Care Alliance NHS Group. I also co-founded the Trans NHS Staff Network, and that's one of the reasons that I've got involved with the NHS Confed's fantastic work at ensuring that we look at LGBT equality across our workforce and supporting our service users. So moving us on to the first conversation that we're going to have today, actually, it's really important that we think about how have the LGBTQ plus community been affected and impacted by the pandemic and by the issues that have arose out of COVID-19. I just wondered if anybody on the panel wanted to open us up with your first thoughts. Feel free to jump in.
I think I'd like to say, I think it's twofold for the communities that I'm involved in. So my intersectionality, so being a person of colour and also being a trans person, that one of the things that I think the transgender population have found is this pushing back. So all the services that are sort of trans-specific, hormone therapies, surgeries, all of that's been pushed back. And I can see what I've recognised from that is that there are the negative impact is lack of mental stability. So mental health issues arising, and I find that exactly the same for the BAME communities as well, where COVID has disproportionately affected that community. Again, that's I think for me, bounce back. We talk about bounce back. I'm not sure how that's going to happen. Particularly, even if there is a virus, there's not going to be there's talk about who's going to take it up, who's going to get involved in taking it.
Peter, you wanted to come in?
Yeah, I've been really struck, and so back in April, I was enjoying the quiet and the solitude. The streets were quiet. I could hear birdsong. I live in London, so I could hear birdsong, and I was actually quite enjoying some of the consequences of lockdown. And I think that you have to remember that for many people that quiet and that solitude is not welcome. And I think what's been shown by some of the research that's been done by people like the LGBT Foundation, like UCL and the University of Sussex, is that actually a lot of LGBTQ plus people have felt very isolated, and they might have been feeling some sense of isolation before, but it's been really exacerbated by the pandemic. I also think that some people have been isolated in households that are not welcoming or are potentially hostile. So I think we've seen COVID shine a light on some of those issues and some of those inequalities that were there before, but which were exacerbated by the pandemic. And so as a result, we've seen an increase in anxiety and depression, and we've seen an increase in people experiencing homophobic abuse and transphobic abuse through the period. And I think that's something that's very worrying.
Caroline, is that something that resonates with you as well?
Yeah, I think that's absolutely right. I think what Ramses and Peter say is bang on. I think if you think about kind of the work that Stonewall did before COVID, and surveying people, and I remember reading those statistics and seeing that like over 50% of LGBTQ responders had felt depressed in the period they were surveying, and that's quite shocking. And the suicide rates are disproportionately high. So a bit like other disadvantaged communities, COVID shone a light on some of those existing inequalities. And I think the issue for the care sector now is going to be about how we prioritise what we do next, and how we make sure that the needs of our communities are appropriately represented.
Gary, how about for you?
I think building on what colleagues have described there is that we know about the strong evidence around LGBT individuals having been at greater risk of poorer mental health, different diagnoses within that, but also we have physical health inequalities that exist too, and we're seeing nationally increases in alcohol consumption, for example, which we know is higher amongst LGBT communities anyhow, higher rates of substance misuse more broadly, higher risk of obesity, cardiovascular in certain groups. I think the important thing to recognise is also that there are minorities within minorities. So when we talk globally about the LGBTQ plus community, there are specific inequalities within the community, particularly around bisexual men and women, for example, in terms of mental health, comparative to gay men. I think another area that we need to look at, and I think this is really important when we look at reset and recovery of services, is about the unequal access to services. So again, some of those surveys from Stonewall, the National LGBT survey that took place a couple of years ago, some really stark narratives that come back from individuals around their actual experience of discrimination, and also their perceived views that they will be discriminated against and not accessing services. So I guess there's something about the extent to which we consider how we target specific communities when we are looking at trying to encourage people back into health and care services.
Can I just ask everybody that's here today? Obviously, one of the things that we look at with equality is we often put people into groups, and we're here today talking about the LGBTQ plus communities. How well do we think that our organisations and sectors are looking at that intersectionality in terms of the impact across our LGBTQ plus community? Do you think that's something we're doing well, or is that something we all need to have more of a focus on? Caroline?
So the last, thanks. So I think it's a really good question, and the last conference that my organisation did, the last kind of big event in February, was on intersectionality. It was our LGBTQ Networks kind of annual conference, and it was absolutely fantastic. It was really well attended by lots and lots of different people. But actually, there's only like a couple of hundred people versus, you know, the 10,000 people that work in my organisation. But it was a real attempt to shine a light. And of course, what it made me realise is the power of all our different staff networks coming together and understanding what it means to be at the intersection and then learning from those experiences. And I think people found it really powerful. It was quite a tense conference, actually, because if you think where I am in North London, there's quite a lot of kind of action around different communities, and there were some quite difficult debates, and it got a bit hairy, but it was really worthwhile. And we did it on, I think it was February the 17th, and we just started seeing our first patients with COVID, and that was it. That was the last big thing we did, and I don't think we met since. So there's we've met virtually, but I think it really brought home to me the power of speaking about intersectionality and that most people don't actually understand it, and it needs to be taken out of academia into kind of the real world, doesn't it? So it's a good challenge.
Peter, what are your thoughts on that?
Well, I think that it's not really surprising that I think that the way the NHS has responded to the disproportionate impact of COVID on disadvantaged groups has been quite heteronormative. I think within the NHS, there's still a huge assumption of heterosexuality in terms of the way policy is written and the way policy is rolled out. So I think that we've had to remind people that when we're focusing on particular groups, that includes people who are women, people who are disabled, people who are LGBTQ plus. But I think there's also a huge opportunity, and I think the sorts of examples that Caroline's talking about shows that there's also a huge opportunity to start thinking much more about intersectionality, where there's common ground, but also where there's difference within some of those characterizations. You know, as a cisgender gay man, my experiences are going to be very different from a trans man or a trans woman or someone who's non-binary. You know, we need to be a little bit more sophisticated in the way we encourage people to talk about their identity in order to provide better care. And I think we're on the beginning of that journey. But I do worry a little bit that some of the responses to COVID-19 have still almost reinforced some of those old behaviours.
Ramses, I just wondered if I could bring you in just to take a non-NHS perspective in terms of how you think the wider sectors are looking at intersectionality. Do you think that's something that's been discussed around the impacts of COVID? Or is that something you've seen?
Well, I mean, it's been discussed, but I don't think really in depth. I know that when the government put out their report about the effects of the BAME community in COVID, they really didn't come with a solution. So it was seen as a sort of half-hearted attempt and not really an area that's really worthy, if you like, of any real discussion. And I think that kind of display of sort of marginalization, if you like, really reinforces what the community is feeling. So talking about the BME communities widely, but also in terms of, if I bring that down to the LGBT section of BAME community as well, again, it's, they feel even more on the margins. And so the discussions are there, but I'm not sure how we are going to, the NHS or us, as healthcare providers are going to really deal with this, because people feel on the outskirts, and they are not talking about getting involved at all because they feel very sort of left in the wilderness, as it were. So yeah, I'm really concerned about how we are going to stop the spread of COVID if large groups of the population are just not going to buy into any kind of vaccine or any kind of, because it's seen as, well, actually you don't care about us, so you're going to use us as guinea pigs. There's all kinds of discussions that are not, that I fear is going to really prolong the situation for one reason or another. There's not, I can't blame the communities for it because this is how it's played out in the last few months for them. So, yeah.
I think hearing all of those challenges that we're seeing there, it'd be really nice to move us on to the next main conversation that we're going to have today, which is thinking about, therefore, what should our immediately in terms of tackling that? What should our health priorities be? Where should our focus be? Looking at that solution focus. If this is where we're at and this is how we're feeling and this is the challenges, all of us here have some type of leadership role and we're speaking out there to leaders in the system. What should people be having as their focus? Just wondered if anyone wanted to open up with that.
I think the word recovery is really interesting. In mental health, we use the word recovery in a slightly different way. And we tend to use the word recovery in the context of thinking about connectedness, of thinking about hope, of thinking about identity, of thinking about meaning, and thinking about empowerment. And I think it's really important in terms of the next steps that we think about recovery, not just as a response to a physical illness, but actually as a response to the impact of COVID on people's lives in the widest possible sense. So I think that's really important. I'm a little bit concerned that if we just respond to COVID, we'll slightly miss the point. Because actually what COVID has done is shine a light on pre-existing issues and pre-existing inequalities. And we've just been through a massive population health exercise, but we need to sort of try and find ways of empowering people across communities to do the next population health exercise, which is actually starting to tackle some of the underlying issues that have had a big light shined upon them. So I think that's where I'd want to start. It's about making sure we think about recovery in the right way and we frame it in the right way. I think my second and final point for this section is that we need to get much better at disaggregating data. We rely too much on averages that mask inequalities within groups and populations. And I think we need to be getting much better at capturing the right data that tells us what's really going on for people in our communities and what's going on for different groups within our communities. So for me, those are the two important first steps.
Caroline, did you want to come in?
Yeah, I was going to make a really similar point actually, which is we just had a whole conversation about the diversity of our community and how that's not always reflected. And of course, you've got to collect data and you've got to collect it sensitively. And we have a really constrained resource in health and social care, don't we? We don't have enough of what we need for the general population.
Yeah.
So we have got to prioritize, and the only way you can prioritize is by having really good data that reflects the needs and the diversity of the communities that we serve.
Gary, could I just ask you to maybe come in thinking about younger people and actually as a system, how do we make sure that LGBT young people's priorities are considered? Have you got any thoughts on that?
I think as a system, children and young people more broadly are not considered in the majority of discussions that we have around health and care services. So I think there's something about raising the awareness and the impact of children and young people. I think when we look at some of the impacts, particularly from a mental health perspective of children and young people from the LGBT plus community, if we don't deal with some of those issues now, we are growing our adult population of service users across all of our health and care services, but broader services. So I think there's something about really raising the voice of young people and hearing what they're telling us. And in actual fact, in Nottingham, we've done lots of work over the last couple of years about working with young people broadly about mental health provision as an example, and hearing the voice of how we would design services with them differently, which gives a very different lens on how we look at traditional methods of care delivery, and that they are involved as recipients of care, but also in the co-production of that care with them there. I think when we look at LGBT young people, the responses are really quite humbling about how simple some of the solutions are there. And often we just don't listen to what young people need us to know to design things differently. And I think for me, one of the opportunities at this point, and we are seeing nuggets of this across different elements of the equality, diversity and inclusion agenda, that we are starting to listen. And when we're seeing the current situation as an opportunity to genuinely reset and restart conversations that we may have failed communities in the past. What we need to make sure is that we're not competing with different communities and strands of equality, that we are looking at all strands relatively. And as we mentioned previously around that intersectionality, that we are a lot more sophisticated, that we aren't looking at more segmentation, but more understanding of people and their various needs rather than their specific needs that are defined by the Equality Act.
I think that's a point about equality not being pie. As much as I like pie and cake, it's been really clear that actually if we focus on this is about everybody. This doesn't have to be about competing with each other. I just wondered, in terms of people that are here today, how do we have that message? How, when we're pushing to make sure that LGBTQ plus issues are prioritised, that actually we don't spill over into that, and we're making it clear to those people that we're challenging that this isn't about stopping something for another community. This is about saying that these issues need to be prioritised too. And that can sometimes be a difficult message to frame. So just wondered if anyone's got any thoughts on how we might do that and the types of things we might say. If I can maybe pass it over to Peter, just because in terms of the LGBTQ plus healthcare leaders network, that's obviously a real key focus for NHS Confed, and maybe you might have some thoughts on that.
Yeah. So, I mean, what strikes me is that this is about seeing the whole person, isn't it? It's not about saying we want to focus on this group or we want to focus on that group. It's actually about us getting better at seeing the whole person. And I think those of us that talk to frontline staff, I mean, I'm always really struck by when I talk to people who are delivering services on the front line, that they quite often say that they feel they're doing all the heavy lifting. Talking to one of our staff who defines as black and defines as a gay man, and he said, you know, I'm just tired of feeling that I'm doing all the heavy lifting. I deal with quite a lot of problems from my patients, which I don't feel I always get support with from my colleagues, and I also get problems sometimes from my colleagues that I don't feel I get support with. And I don't think that was an isolated voice. I think that's something I've heard, you know, resonate in a number of conversations I've had on the front line. And I think it's something about making sure we see the whole of the person in order to then deliver a better response for our patients. I think that also we need to see the whole of the patient, and we need to recognize that if we don't understand the context for the patient and how they see themselves, then we're not going to deliver the right kind of care, and they're not going to recover in the right way. I think a really good example of that is the work we've done with the homeless population. We know that younger LGBTQ plus people are much more likely to be homeless, and they're a significant part of the homeless population. And the solutions for them, actually, if we focus on that, will actually benefit all younger people, because actually we will start to look at what some of the underlying causes of that are. But we also need to recognize that there are some very specific drivers that we need to respond to specifically.
Has anybody else got any reflections on what Peter's just said in terms of how you might approach that conversation about equality not being about pie, as much as we might like pie?
One of the things that I thought, you know, it raised for me was I think it is really important to think about the whole person, and you know, the NHS and the care sector is very heteronormative, and so we know just through our policies and procedures how when we approach someone, we make no assumptions. at all about how they look, and it's about asking questions. But one of the things that I've discovered in the time that we've been in operations, our staff come from a variety of places, and what that does is that when we have training, say around HIV, and everybody is involved in the training, and I think that's how we're going to tackle this. When it's not, when you talk about your colleague feeling like he does all the heavy lifting, yeah, it is. Oh, this is your area. You deal with it. And actually, we should all be able to deal with everybody that we come in contact with, and that comes from training. And I think the more that we understand, we understand the differences, and I think that's another thing, is that we need to be able to feel comfortable about making mistakes, and when we do make mistakes, we support each other in correcting and learning. So, people are very scared. They say, I'm scared of saying this and I'm scared of saying that. But it's okay to ask. It's just, and if we're taught how to ask appropriately, but it really does make a difference, because I don't think, in my experience, I don't think the LGBT population necessarily, if they're going to the doctors, need to see a doctor from that community. What they need is someone to understand who they are. My doctor is sort of a middle-aged Indian woman who completely understands me, and she's married, and I'm great with that, because she takes the time to understand me as a person. I think that's what happens, and once we start to get that into the culture of the services that we deliver, people are going to feel comfortable.
Yeah.
I really love that there about the learning from mistakes. If anyone follows me on Twitter, it's my pinned tweets that actually it's really important that we learn from mistakes, and actually we accept that we'll make mistakes, and that's one of the main ways that we learn. So it's a really great message for people to hear and take away today as well.
I think we're
just going to say, Peter, I think Gary wanted to come in.
I think one of the challenges, and I understand the sentiment of what Peter's kind of coming from, because actually many of these have been echoed by frontline staff that I've spoken to through some of my work around that sense that we need to see people as the whole of the person, and that actually if we were to be looking at person-centered care, that's the ultimate ambition, and I get that. I guess there's something about where we are now and how we get to that point, and how we give people the knowledge that actually, if you're working with somebody that might identify as LGBT, these may be the things that you need to know about that. These might be the things that don't define that person, but you may kind of need to consider how they interact with you, kind of what their potential risks are, those kind of things there. And I think that's one of the challenges about how we look at engaging in dialogue with people around raising their awareness. As a gay man, I don't want to be defined by the statistics which tell me I'm going to have all of those predicted outcomes. That's not necessarily where I'm going from, but I want, when I go to my GP or a healthcare professional, that they understand that actually the way that I interact with services might be informed by my experiences of homophobia. Those kind of things I think are really quite important, and how we engage in those conversations. So I think the training is really quite important, and how we create that psychological safety for staff to ask the things that they perceive people, what that they feel they should know, but perhaps have never been given that space to ask curious questions. And just one example of how we've done that within my own organisation recently is we've recently launched our staff network, and what we've done for staff across the organisation have just had over Teams coffee catch-ups over lunchtime, so people can come ask about the network, but also ask some of the questions that might start to inform how they think about the recovery. What are the specific aspects around LGBT communities that they need to take into account when they're preparing their recovery plans, and so on there. So that's just something that I wanted to share as an example of how we've done that. And what we've tried to do is coordinate that with the other staff networks. So there is that sense of intersectionality, and that view that we are considering the differences that we all present with.
Peter, you wanted to come in?
Well, no, I was just sort of thinking about allyship. I think that sometimes, we need to think about, one, I think there's something about how in organizations managerially we support people at the front line, and we allow space for the conversations to happen at the front line. And I suppose some of the ways which Caroline was describing, bringing the different networks together, is a way of doing that. But I think there's also something about how you promote allyship and allow people places where they can ask questions, but also actually we all need, if we're going to talk about inclusive leadership, we all need to be willing to hear when we get it wrong. And I think one of the things we need to model is hearing the challenge and responding to the challenge and thinking about, well, how do I need to change to lead this organization better? How do I need to change to be part of this team better? And I think it's getting that dialogue, being willing to hear difficult messages and responding with curiosity to those difficult messages, and developing the allyship, because, you know, within LGBTQ plus, we need to develop allyship. But, you know, I need to learn more about how I can support trans colleagues who I think are having a very difficult time at the moment, and it's a very toxic environment for trans colleagues. But I need to learn and listen to how I can be a better ally within that.
Peter, I think that's so important, and actually that recognition that even within our own community, actually it's understanding privilege and how that privilege can intersect across our many different identities that we bring to the table, and often we don't talk about that outwardly to people that aren't LGBTQ plus, who just see us as a homogenous group, as if actually we need a training session on LGBTQ plus issues or awareness, not recognizing the depth of challenges and identities. So that's really important, I think, to highlight. Caroline, I think you wanted to come in.
Yeah, it's such an interesting debate, isn't it? So for me, a lot of this is the leadership job. Back to your challenge, Tara, around what's our job. I think ultimately it's about inclusion, and you want every single member of staff to feel included. And I've got to the point where I think, God, maybe I just need to ask maybe we need to poll all our staff, regular frequency, and just say, does my manager make me feel included? Yes or no? Because if I was someone's manager, I would want to know that, wouldn't you?
Yes.
And I would want to know that they were like Ramsey's GP and they'd taken the time to understand me as a person so that I can bring my whole self to work. I've been really struck by I've been talking to our BME staff network recently, and some of the comments from colleagues there around, I feel like I have to suppress a bit of my personality, leave it at home, come to work a bit switched down. And I was thinking, oh my God, I lived my 20s and 30s like that, because I didn't really come out at work until, a bit later. And you just think you want people to bring their whole, they need to be whole and they need to feel included. And then I was thinking about this failure point, and I've got a 10-year-old daughter, and they teach them to fail, right? That you can't learn unless you fail. It's okay to fail, and you've got, we've got to carry that into adulthood, haven't we? And it's absolutely all right. We've done a lot of work mimicking what happens in organisations that provide mental health services, actually, Peter. So I think the acute sector's got quite a lot of work, learning from your sector around. We think you've done more work with your staff on wellbeing, and we look at you with envy. And now we've realised that you might have more answers than we do. So there's something for me around actually saying, okay, I don't have all the answers. I may be in a big teaching hospital, but actually people out in the community, people in mental health services, people in social care have done a lot of work on this that we haven't. So there's something for me about learning to follow, actually. Well,
I think this is a really good segue onto the next thing for us to talk about, in terms of actually what are some of those longer term changes that we need to make. What are some of those areas that we need to look at our organisations and have an impact on, so that we can focus on the long term health needs of the LGBTQ plus community, and those health inequalities that existed prior to COVID-19 that have just been amplified by what we've seen. So there's all sorts of things we could look at, thinking about our data systems, thinking about how we use pronouns, thinking about good practice, thinking about the learning between the VCSE sector and the NHS. So I just wondered if anyone wanted to start us off with where you think we should be starting with that longer term vision. Where should we start first? Because there's so much for us to look at. Gary.
I think segueing from the previous conversations around leadership, I think if we use that as the fundamental basis of where we start there, and I think I'd encourage viewers to have a look at a document that was recently published by the University of West England as part of the Building Leadership for Inclusion programme led by NHS England and the Leadership Academy, and that has got some really insightful outcomes that move beyond some of the good intentions and the symbolic actions that we've taken in the past that perhaps haven't necessarily driven the scale of change and help to reduce the inequalities that we are seeking to achieve there. So I think that takes a much more culturally sensitive approach of how we look at those things around power, around allyship, around the way that we see equality, diversity and inclusion as a wicked problem for organisations, rather than something that we can kind of do surface level responses to. And I'm minded by a conversation we had recently, Tara, around how we move from, again, some of those surface level intentions or good intentions as they are, but actually that we set more challenging and targeted outcome measures for actually demonstrating change, rather than just talking about wanting to see change there. So where do we want to be in 4 years' time, and working backwards from that and taking targeted actions that will help deliver some of those priorities that we want to all achieve, rather than if we do this, we hope this will happen down the line. And I think we can be using the data and our own kind of knowledge and working with communities to be able to drive more targeted interventions that make a real difference to our workforce, but our service users as well.
Gary, that sort of sentiment of actions, not words, I think it really resonates with me. And I've sort of coined a phrase over recent times: this, are leaders just catching a cricket ball? Are they really just saying what they need to say so that things don't impact and it's harder to challenge? Or is there something really behind it? So that's something that I'd ask people to think about when they're looking at their leaders. Are the statements just catching cricket balls? Are they just saying what they need to say so that you can't challenge them? Or is there a real outcome focus behind any work behind that? And just thinking about, Peter, just some of the specifics that we could do moving on that. What are some of those actions that we could actually start to build into our organisations? Have you got any ideas, Peter?
Well, I mean, I think that I'm really struck that we've got to think differently as we move forward. We can't just restore and go back to what we had before. There's got to be a change. And I think that one of the things, certainly if you look through a mental health lens and you look through a mental health and well-being lens, then I think we've got to start thinking about actually how do we work with people within our local communities and actually make sure that they have the skills across our local communities. Because I think one of the things that really interested me around our initial response to COVID-19 was how we managed to bring people together at a community level to respond practically to a lot of the things that were going on. And that we mustn't lose that. There's a risk, I think, that we then start to lose that and don't build on it. So I think there is something about making sure we capture the right data. I think there's something about making sure that we don't normalize inequality across the system. And I sometimes think if we're not careful, we just get into the habit of saying that certain people are lower paid, certain people live in multi-occupied housing. LGBTQ plus people are more likely to express suicidal ideas of suicide. And it's a bit like, actually, if we're not careful, we almost normalize some of those statements. And it's about being willing to collect the right data and then make sure we're actually really focusing on actually reducing inequality, and that we set ourselves, particularly as we develop our integrated care systems, we set ourselves the right outcome measure actually going to reduce inequality across our different communities. And I think that's the place to start. And I think certainly then thinking about making sure that we're reducing levels of suicide, we're reducing levels of homelessness. Those things that particularly affect the LGBTQ plus community need to be captured in a range of outcome measures that we're focusing on.
Caroline, you wanted to come in?
Yeah, I was when Peter was talking about normalising, I was thinking about I loved your phrase about catching a cricket ball, by the way. I thought it was brilliant. But there's the normalising thing. We have a phrase which is people learning to walk with a limp, and that kind of, you just get, and that's absolutely what we've got to avoid doing. I was struck during the first wave of the pandemic by that kind of visceral sense of common purpose that people had, and it brought people together in a completely different way. And Some of that persists, not all of it, but some of it. And in my bit of the world, you know, I am working with completely different people to the ones I used to work with. I'm working with mental health colleagues, with community colleagues, with people from the voluntary and third sector, and from social care in a way that hadn't before. And I'm learning stuff from them all the time. I think the trick now, to coin another phrase, is not to boil the ocean, but to come up with a couple of priorities that as systems we have. The other thing for me is to use existing channels. So some of those we've just invented, but also we've got really good staff networks emerging all over the country now in all our sectors. And actually they are like a really massive asset. So for me, getting back to that conversation about intersectionality, actually getting the networks to connect on some of these key issues so we don't compete, but actually we align. And actually we can come out of this with a sort of clearer set of priorities. In my organisation, we've just set up I've never really used the phrase EDI, equality, diversity, inclusion, but actually it seems to have gone down quite well in my organisation. So we now have a kind of task force, and we call it a task force because we're only going to do a few tasks and we're going to make sure it's focused on delivery. But it seems to have kind of captured and galvanised a bit of energy. And it's that thing about where there is energy, you kind of got to go with it. And that's one of the leadership tasks, isn't it? Don't try and invent something else, go with the energy. And there's still, certainly where I'm, a little bit of energy for this. So a few things: don't boil the ocean, and don't learn to walk with a limp.
Ramses, can I bring you in terms of how we maybe learn as a broader health sector? How do we share actually where there's good practice outside of the NHS, and actually we learn from that? Because I think there's often gets missed. We often look as silos. It'd be really great to hear your thoughts on that.
I think I was just thinking about what everyone has just said, and in terms of inclusion and leadership, I think is that word stands out for me, and the who has the power, who is in control. And I think it's really important. I come across this all the time. Position will be up and they'll say, well, we were going to give it to these people because they have the experience. But the same people have the experience, so the same people will continue to get the same posts. And what we need is diversity in leadership. Because if we don't have diversity in leadership, it's going to be extremely difficult to change the way, the general consensus. If I can't imagine something, I can't bring it to fruition. And if I've got some experience of it, so I think it's important. It's important for me to be able to see trans people sort of openly in leadership. It's important for me to be able to see the AME people in leadership. And it's equally important not to have people tell me this is what I need and this is what's gone on traditionally. So we need to upskill people. We need to bring people in so that the leadership looks different. And if the leadership is different, the leaders are then challenged, and they're not just catching the cricket ball, because there's going to be people there that are going to positively challenge, and we're going to have to think about how we're going to move forward. So I think that's the main thing that needs to happen, and that will trickle down. If the leadership is different, if the leadership starts thinking differently, it will trickle down to the bottom. It's a top-down approach, I think.
Peter?
Yeah, I mean that really resonates for me. We know that organisations that have a diverse leadership are much more likely to be creative and successful. We know that when leaders encourage people to voice different opinions, they encourage people to be their authentic selves, then that breeds organisational success. But we also know that LGBTQ plus staff are less likely than others to believe that their organisations actually are successful at fostering an inclusive culture. So I think we have a way to go in terms of making a reality of inclusive leadership, but really resonate with what Ramses is saying. My slight concern that sometimes when we talk about inclusive leadership, we present it as a bit as if it's a virtue, and actually it's a series of competencies, and it's a series of skills and behaviours that we need to embed in our organisations. And I think that for me is the next step. It's recognising the importance of diverse leadership and then actually embedding the right behaviours across the organisation. So it's so important, and it's particularly important, I think, for the LGBTQ plus community.
Gary, you wanted to come in? You're on mute, Gary.
Somebody had to do that today, didn't they?
Oh.
I think the bit that I would add around that is about the accountability that goes along with that. So again, the cricket ball isn't, people are held to account for seeing that as the kind of their responsibility there, but actually it goes beyond that. I think from experience of being involved in some of the national leadership development work around inclusion and leadership development, some of the feedback from individuals that were part of some of those focus groups was around how many people, the more senior they became, the more they joined the country club and they adapted their behaviours, and actually they became less of their authentic selves within that. And I think we need to consider that whilst we've got some senior colleagues on the call today, that may not be representative elsewhere. There may be something about geography in different parts of the country where it's more difficult to be kind of your authentic self, and that actually we don't water down people's identities the more senior they become. And we see that across different strands of difference there. But that is something that I think we need to create the environment where actually we're breaking down the country club. We're not conforming to what that becomes in the future.
Gary, as I'd probably get thrown out of a country club, and as I've never watched a cricket game, I'm hopeful that that isn't the future, thinking about my career as I advance in the health sector. So fingers crossed that we can challenge that. I just wanted to add, from my perspective, some key messages as well, just that we need to educate our leaders to understand the scale of some of the challenges around LGBTQ plus inequalities. We still have IT systems which refuse to accept that trans men can have a baby and can get pregnant, and that say you must label them as women, otherwise they're not allowed to be on our systems. Most of our leaders don't know that bisexual staff often have the worst experiences in our workforces in terms of the NHS staff survey when we look at that data for a lot of organisations. And so probably message from me for people watching today is making sure that you go and learn some of those specific facts and some of that level of inequalities that exist, rather than just the broader messaging around there is inequality, because when you dig into it, it's even more shocking than many of us actually realise when we look at the surface. I just wanted to move us on to our which is just looking at our workforce considerations, is what do we need to do around making sure that LGBTQ plus inclusion is central to our workforce development, thinking about the people plan, thinking about our own organisation people plans. How do we make sure that all of our staff feel that they can bring their whole selves to work and that their issues are considered and prioritised and that we're tackling those inequalities? I think, Caroline, you wanted to come in.
Yeah, well, you mentioned the people plan. There was that slightly awkward moment when it was first published, wasn't there? And it's really important to get language right. And I think we've made this point on this call before about actually we got there's an allyship issue here, isn't there? About making sure people understand what it means when you use the wrong language. Actually, that's really important, isn't it? Because I couldn't believe the first edition of the people plan. I found it quite incredible, and I sort of found out about it after the Twitter storm. So great that they corrected it, but actually it highlighted a wider point. Actually, it's a learning moment, isn't it, for everybody? Because and we must use it. We have a responsibility to use that as a learning point, to reflect that reporting sexuality is really important, reporting gender is really important, reporting all the brilliant diversity in our community and getting it right, and then reflecting that back to people is super important. So I think great that the people plan has an inclusion bias and a well-being bias, but it is just a very, very top level plan, isn't it? And actually the job is on the ground, and it's with us and our frontline staff to really get that right. And I think the things that this conversation has been really helpful for me actually personally around making sure that I take the learning from the different sectors around, and that we do. I think we have to ask our staff if their managers make them feel included. I think that's one of the most important things we can do, because it's a really symbolic. It's a bit signalling, isn't it? And it's a bit signalling that says you're really serious about this issue. And most managers, I think, would want to know whether they were making people feel included or excluded. I think that's kind of the single act that for me might make quite a big difference.
Caroline, I just want to link that back to the conversation we had earlier about learning from mistakes. I think most of us were shocked and disappointed when the people plan came out in terms of the lack of LGBTQ plus inclusion, and particularly trans inclusion. But then since then, I know I've had a personal email from the Chief People Officer as someone who founded the Trans Staff Network. We've had trans and non-binary specific roundtables, LGBTQ plus roundtables. And as a passionate advocate for equality, I'd still say we need to do way more in pushing this agenda forward. But actually, that's never happened before. And I think it's really great to see that learning from the mistakes that have been there. I know, Peter, you've been involved in some of those conversations and equally as passionate as me. Have you got any reflections?
Yeah, I mean, I think, so a mistake was made, it was then corrected. I think it did show us how far we've got to go, both in terms of an understanding of LGBTQ issues, but also I think actually that lack of allyship, that it tended to be LGBT staff who raised the issue. But I think we now have a different kind of conversation, and I think we now have an opportunity to really involve LGBTQ plus staff across the NHS in the development of the next stage of the plan. I do think if this year is meant to be about equalities, then I think there is an issue for us as employers to look at the experience of our trans staff at the moment. And I wonder whether actually all of us as employers are doing everything we should be doing to address what trans staff are experiencing. And it's certainly something that the board of my organisation has talked about. Are we doing everything we can to support them with some of the aggression that they're experiencing, both from patients and from colleagues? But I do think that we now have a different platform for the next stage of the people plan. I think for me there's something about the staff networks. I think staff networks are an incredibly useful tool because they work right the way across an organisation. They work across the different departmental boundaries that there might be within an organisation. But the research that came out from the University of York, was it a month ago? I think created some really important messages about, one, that you have to create the forums for the networks to come together. They have to be resourced properly. People need to be allowed the time to participate. We need to recognise it will be easier for some kinds of staff to participate in networks than it will be for others, and they need to be connected to the decision making for within an organisation, because there's got to be that connection. But I think the support of staff networks, and I think the work we're starting to do in terms of bringing some of the networks together across the NHS is potentially very powerful, because I think it gives us an opportunity to create a social movement, and it gives us an opportunity to really amplify the voice of LGBTQ plus staff, which I believe will then benefit all patients, but particularly LGBTQ plus patients.
So one of the things I'm passionate about is making sure that it's our frontline colleagues and our colleagues who are in often more junior roles are heard. And often I'm in rooms where, like us today, we're all relatively senior in our organisations, and they're the voices that get heard in our systems. And I think when we are there, we've got a responsibility to make sure that we're not just speaking as ourselves, that we're trying to look for ways to bring other people in. But how do we make sure that we're hearing those real experiences, that people have time to get involved with staff networks, that those voices can be heard if people don't have time to get involved in the staff networks? What can we do to make sure that those voices are still central to our work as well? Has anybody got any thoughts? I think, Gary, you wanted to come in.
I think on that basis, and also picking up what Peter was describing around the value of staff networks, is that it presents the lived experience that otherwise may not be presented within an organisation. And there is that challenge that the networks are resourced, and I think coining a phrase from a network lead within a North London provider, mental health provider, I think, around they have a day job and a gay job. And actually that is often requiring people to do work over and above their hours to kind of do the other bits, and not that being recognised is important there. I think the other bit about people being involved in networks is the emotional labour that's involved, and ensuring that people not only have the time, but they have the emotional support to be able to manage putting yourself in front of people around that. I think there are obviously things around reverse or parallel mentoring that are going to be quite important in terms of exposing people to the realities that otherwise they may not see. And I think for me, one of the benefits of that, and my own organisation are keen to be part of this, is that actually those that are in decision-making positions are able to put themselves in the shoes of other people. And I think that's at all levels of an organisation. And again, it addresses some of those power imbalances potentially there, because I mean, the more work that I've done around this, I look at some of the statistics and the experience of others in disbelief, because that's not my own experience, but you have to challenge yourself around that. So the points that you make, Tara, that actually my own experience, I've escaped relatively unscathed this part, and that's probably not hurt my career in terms of that. For other people, their experiences are very different, and we need, you know, the stuff that comes out of the Stonewall and Healthy Attitudes reports and those kind of things, people to believe that that's the reality. Because when that is saying that only 33% of people believe in the NHS that we should be doing more for LGBT people, that means 67% of those that we work with don't think we should be doing more. And that's kind of that's the tide in which we need to kind of reverse the cultural kind of norms that exist within parts of our workforce currently.
Ramses, you wanted to come in?
Yeah, I just wanted to, I suppose I'm just thinking about what Gary said. I think it's really important. I think one of the things that I was thinking about is about you've got to be able to allow people to speak up. So whatever the signposting is, people have to be able to feel safe. And when you talked about people not bringing their whole selves to work, if you've been sort of trained, you know, through your whole life to suppress, then you're not going to be able to speak up. But also the other thing is that when someone does speak up, you know, we've got to be able to listen. You know, their reality is their reality. And so what you get, even if you think in terms of the sort of the AME communities, if we say, oh, this is institutionally racist, and someone says, no, it's not, the arguments, that's it, it's null and void. So there's nowhere for us to go. And I think in terms of the LGBT community, that's the other thing, is that we need to be able to have the space that leaders and people who are in power listen without trying to fix it straight away, or without telling us this is not our reality. You know, the stereotype that I know is the reality, and that's what you've got to go with. So yeah, we've got to create spaces where people inside of the networks, where people feel safe, where they can be their whole selves. And then again, like Gary said, supporting, because it's quite traumatic to continue to bring up a situation when you keep continually getting pushed, you know, knocked down. So if I continue to talk about, you know, this is my reality, and I've done it for 20 years, and, you know, people don't listen, then why would I then, you know, if I get shot down in a negative way, it becomes trauma for me. So then I'm trained, if I raise an issue, what I'm going to get is trauma. So I shut down. So, you know, we've got to create safe spaces, and it's going to be tiny things inside of networks, small signposting that make people feel welcome, that make people feel safe. So it's safety. That's the overall thing, I think.
Linking this conversation back to something we said earlier around the need for an outcome focus, we know that for many of our organisations, both sexual orientation data, the quality of that data isn't as such that people feel safe or confident in sharing that information, and gender identity data isn't recorded for our organisations, and people aren't able to share their gender outside of the binary for most of our organisations. How do we measure and make sure that the things that we're talking about here have the impact that we want? Because we talked earlier about this need to not just do things that feel nice, but they actually have to benefit the colleagues that we're working with. Has anybody got any thoughts on what we do within that sort of context? Ramses, do you want to come in?
Yeah, I think it's important to recognise that it's going to be small steps, but it's going to be small steps continually. I think when we talk about these issues, we somehow think that we're going to go away and have this blanket fix, and it's not going to do that. So whatever we do, you know, I think as long as we come up with plans, and we continue to keep moving, and we're not disheartened when something doesn't produce. You know, we've done a survey and we haven't had 200 recipients. You know, we continue to do the work because it's going to take time. I think that with COVID, definitely there is a sense that we are together as a country, even against the rest of the world. And we are, and I see it as a unique opportunity for us to build bridges now, because people are openly speaking. And I think it's an opportunity for us to small steps and just to embrace each other. I think that's what we need to do. It's going to be tiny steps and to keep positive.
Peter, you were mentioning some of the actions that your organisation was taking. I just wondered if you'd be able to share maybe some of those small steps that we've just heard. Is there any actions that you think that you're doing that might be of benefit to other trusts that maybe are further behind in that journey?
Oh goodness!
Sorry for putting you on the spot.
I think we're still no. I think we're still at the beginning, but I think there's something about wanting to create psychological safety, and there's something about trying to work with the net to ensure that the networks are properly resourced, about trying to make sure that they are connected to decision making. I think it's also important to create spaces where the networks come together, but that there's a proper balance between making sure that the networks are setting the agenda and setting the areas for discussion, and that the organisation isn't sort of imposing its own agenda too quickly. Obviously, it needs to link to the strategy of the organisation, but nonetheless, I think that the networks both need to be developed individually and collectively, and then connected to the decision making. I think one of the things I've learned is the importance of really making sure that the board is asking for disaggregated data. So it's constantly giving the message that it wants to understand what's going on for different groups across the organisation, but that it's picking the right meaningful metrics, and that we're listening to what community members are saying are the meaningful metrics. And I think for me, there's something about, I come from a particular generation. I went through a particular set of experiences, and I'm constantly interested in learning about what visible leadership means to staff members who are from different generations than me, because I can't define, nor should I try and define what visible leadership is as a cisgender gay man. I need to hear what kind of visibility they're looking for from their leaders, and then try and create the right environment for them to be able to do that.
Ramses, you want to come
in? Yeah, I mean, I run a small organisations, so I can't even imagine the tasks that a lot of you have in the NHS. I wouldn't, it's easier for me to be able to train my staff and say, everything. We talk to people with non-binary. It's what we don't assume anything, but I can't imagine how you would get that through in the NHS. I do think that the NHS. I definitely see a change in the way people are reaching out, and I know with the Royal Free, I'm part of their program in terms of the LGBT awareness and stuff, and I think that's all we need to do. I think that Peter is quite right. I think the networks are going to be really important, and listening and leaving, allowing them to have a voice, and just looking. I think like what the Royal Free is doing, just looking at your policies, looking at how supporting everybody to be able to deliver what's necessary, and it just means sort of like segueing out and just going through these documents. If I turn up and all that, I filled out a document the other day and it said Black British. And I was pleased because it never said, that's the first time I've seen it. It normally says Black Other. And it also said White British, which made me think, oh, someone's listening. And it's those tiny micro signals that people feel included for. So I think that's what we need to do. Examine where we are and just put small steps in place to try and get it right. But I think what Peter said it makes a lot of sense. The networks are going to be very useful, I think, to the NHS.
Thinking about those steps, and I always think it's good to finish sessions like today with some real reflection or actions for people that have been watching and joining us. And I just wondered if I could ask each of you if you had one message, one action that people should take after watching today's roundtable, watching today's discussion, what would that be? And if I can pick on Caroline to go first, if that's okay. Sorry to put you on the spot like that, as what your takeaway action is.
Okay. If you're a manager, make sure that you genuinely get to know the whole self of the people that work for you. And if you're not a manager, make sure that your managers do that.
Peter?
I think we need to hold leaders more to account, diversity of the leadership that they have around them and the diversity of the leadership they encourage. And I would expect as a chair to be held to account for the diversity of the board and the senior leadership of the organisation. And I'd be expecting to see a light shone on that continuously, to make sure that it's actually happening and it's not something that we just wring our hands about.
Gary?
What hasn't been said? I think for people in any role within health and social care, what I would encourage people to embrace is their vulnerability. What they don't know, listen and be curious. So don't take some of the information that they receive on first hand. If you've got data, look at what it's not telling you. Asking questions and educating yourself by speaking to those that might know a little bit more than you, because often those people are willing to share their experiences and help advance things around this. So yeah, I would say embrace vulnerability and be curious.
Ramses?
I like that idea of the country club, but I think that it's really important. The country clubs are there, but it's important to understand that to be your whole self, you can go there and be yourself. The notion that I have to sort of turn into somebody else, and I think it's that gives us confidence, and just to understand that being your whole self will change the way other people see themselves. So yeah, go to the country club and be your whole self, because someone else is going to turn up and they're going to be their whole selves. And before you know it, the whole ethos of the country club is going to change. So yeah.
That sounds like some fantastic actions for everybody to take away that has been joining us today. I know we've had just such deep conversations that I've taken away a lot of learning. I just wanted to thank everybody today, all of our speakers, everybody that has joined the conversation. If you've taken time out of your day to watch and actually learn from the conversations, I wanted to thank you, because it's important that we're intentional about LGBTQ plus inclusion. It's not something that just happens by actually us saying that we care. We actually have to take that time. So if you've taken time to join us, that is so important. So thank you very much. I'd also like to ask you to read and commit to the recommendations that will be attached to today's recording as well from NHS Confederation, as we go forward together tackling LGBTQ plus inequalities both in our communities and in our workforce. Thank you.
Thank you.
Thank you.